Our next speaker is from Taiwan. He did his medical degree at II University and his surgical training at National Chen University Hospital for surgery, as well as fellowship in cardiovascular surgery. So allow me to introduce Dr. Chen, who will present to us another case of a severely angulated neck.
Good morning, ladies and gentlemen. Sawadee Krap. And I'm Dr. Chen from Taiwan. It's my honor to be here to share my experience with you. And the first case is about a 75-year-old man with abdominal aortic aneurysm rupture. Actually, the patient first received thoracic aortic stent treatment at another hospital. However, for the unfriendly anatomy of the abdominal aortic aneurysm, the patient was waiting for the fenestration or T-print, something like this. However, during the period of waiting for further surgery, the patient presented with rupture of the aortic aneurysm and was brought to the hospital. And upon arrival, the patient presented with shock, profound shock, and underwent CPCR. During this emergent situation, we had no choice but to treat the patient to save the life, and we chose the endovascular treatment for the established data that endovascular treatment has better outcome than surgical treatment for these emergent and rupture cases. Although the endovascular treatment was so successful and we stopped the bleeding and restored the hemodynamic, however, the patient presented with compartment syndrome, abdominal compartment syndrome. So we opened the abdomen to perform decompressive laparotomy to save the life. After several weeks of intensive care, the patient survived and was discharged uneventfully. However, during outpatient follow-up 6 months later, we found the patient presented with type 1A endo leak. Because the type 1 endo leak was due to the proximal sealing zone progression growth. We have no choice, so we did another CAT scan. We found huge type 1A endo leak. For confirmation, we try to do repeat aortography and engage it into different vessel branches to make the diagnosis confirmed. And we want to exclude if there is any other type of type 2, type 3, and type 4 endo leak. However, even after the inflation of aortic balloon in the proximal side, we do the aortography. We confirm there was only type 1A endo leak. In further detail, aortography and angiography disclosed there was a gap or slit in between the aortic stent and the aortic wall, just like dotted here with the red dots. And the figure of A-shaped slit or gap is the main reason or main cause of the type 1A endo leak. During this period, endo anchor was not introduced to my hospital before. This patient presented several years ago, so I have no choice but to engage and try to wiring into the gap of the figure of A gap of the slit to try to embolize it. So I put a catheter into this gap and put so many emboli coils for embolization. Just like I mentioned before, the gap was in a figure of A shape. So I put some coils in the lower belly or lower circle of the figure of A gap and some coils in the above one. And then I put another catheter into. So here I got 2 catheters in the sock. I put both these 2 catheters into the sock, the huge one, and I try to inject some gel foam and bioglue. As we know, the bioglue is what we used to do in the open aortic surgery as an adhesive at the outer side of aortic wall or even some vessel wall. And as you know, bioglue contains 2 separate components, including bovine serum and glutathione. If these 2 separate components were injected into via the same catheter, we will lose the catheter because the early occlusion or adhesive material inside the same catheter. So I tried to inject the material in different two catheter. Then finally, I get a promising result. There was no more endo leak during follow-up. In the second case, I also tried to embolize and delay type 1 endo leak 12 years later noted after the initial treatment. Because the proximity of the endo leak gap and the left renal artery, I tried to insert a wire into a left renal artery just for protection, and also put some coils into the gap and stop the 1A endo leak. Why this happened? Because for this patient, we have unfriendly anatomy of the proximal sealing zone. We have wide with conical, we have different types of unfriendly anatomy. For this unfriendly anatomy, we have higher possibility of neck growth even after endovascular treatment. After serious follow-up, we found that we have progressive enlargement of the type 1A sealing area. In the proximal sealing area, once the aortic neck continues growing, we lost the proximal sealing zone. So we have so many choices. We can choose open surgery, to do hand suture even at higher level, to do cervical abdominal surgery, cervical abdominal treatment. We can put and cuff at the proximal side to reinforce or to extend it. We can do chimney. We can do fenestration. We can do T-branch. However, all this treatment has its side effects and higher morbidity and mortality, and we have longer time for waiting. We have complexity of the intervention. We have other choice. We have endo anchor. After the previous two cases, endo anchor was introduced to my hospital. So in these cases, I found delayed 1A endo leak 4 years after the initial endovascular treatment for the AAA. As you can see, similar anatomy. So in the beginning, I tried to do similar procedure. I tried to engage into the left renal artery. I tried to extend the proximal sealing zone because there is a tiny different distance between the lower part, the renal artery, and the superior mesenteric artery and the right renal artery. So I tried to extend it, but failed. So in the next step, I tried to extend the proximal as well as chimney, or you can say periscope for the left renal artery. However, but in vain. I still have the type 1A endo leak. As you can see, even after elongation, proximal extension, and chimney of the left renal artery, the type 1A endo leak persisted. So I use endo anchor. I screw the proximal side. Even after 2 layers of proximal aortic stent, I screw it onto the native aortic wall and stop the endo leak. As you can see here, there was no more endo leak. Even during the following up, there was no more endo leak in the CAT scan. So what we learned from the previous 3 cases, in the previous 2 cases, we have no endo anchor. We choose other alternatives and adjunctive procedure to stop this problem. And for the 3rd case, we choose endo leak as an alternative or a salvage to stop 1A endo leak. And for this case, it's a fresh case. Upon the first time we do the endovascular treatment for AAA, you can also see on the CAT scan and 3D reconstruction, the anatomy was also unfriendly. Shown in tortuous neck, in coronal and sagittal view, you can see the unfriendly proximal sealing area. After the initial main body stent deployment, the type 1A endo leak was noted, even after ballooning. So I choose to use endo anchor to stop the type 1A endo leak just screw the aortic stent onto the native wall. And you can see in the very beginning, in the same surgery, in the same operation, we stopped the type 1A endoleak. And during the follow-up, there was no endoleak, and the patient survived until now. So what we learned from these totally 4 cases? In the previous period, we have no choice but to, just like I mentioned, I use other than fenestration, chimney, or embolization to stop the problem. However, once we have endo anchor, we have another new choices to stop the 1A endoleak as the screw. Due to the studies, we can see once the endo anchor was used, we have higher possibility to stop the type 1 endoleak and make the patient free from later mortality, mobility, neck expansion. So in the past, we prefer to use endo anchor helifax as a salvage to treat the problem. But just like we know, for all the patients, even without initially 1A endoleak, the aortic neck would progressively enlarge it. So once we lost the proximal sealing zone, we will have more difficulties to stop 1A endoleak. So prevention is worse than treatment. So if we start treatment, the endoleak in the very beginning, we can choose endo anchor in the same situation, in the same surgery, in the first surgery to stop it, rather than to prevent it in the future. So that's my case sharing for the endo anchor and what I learned from these 4 cases. So in the end, I want to say that I like Thailand very much because I'm from Taiwan, and the city I live in is called Tainan. As you can see, as you know that the 2 cities, Tainan and Thailand, sound similarly in pronunciation. This is the first part, and these 2 cities, Tainan and Taiwan, Thailand, are both very hot especially in summer. We also have some cooperation exchange program with the Mahidol University in Thailand. And during this summer vacation, there are several exchange interns at my laboratory. So it's my honor to be here. And thank you very much, Hukan Kap. Thank you.
Thank you, Dr. Chen, for sharing very tough cases. We probably have time for 1 or 2 questions. Any questions from the floor? Yes, sir.
Thank you for a very wonderful case that you present. I have a question for the angulated neck for Dr. Vila and also Dr. Natapon that present the angulated neck. Usually when we do the standard EVA in the severe angulated neck, we often have got a suggestion from the technician that we may oversize for the 30% to ensure that the stent graft is at position to the aortic wall instead of the 10 to 20%. But if we use the forcing wire and push-up technique that made the aortic graft conformation to the aortic wall at the neck, how do you oversize the stent graft? You with 20 or 30%?
In my small series, in 13 case, the oversize is 20%, and with a different technique, with the soft wire, with the 2 and 2 wire, not used for the stiff wire.
Yes, I also agree with that because I have a case of the severe angulated neck and also the calcified neck too. After we got the suggestion of using the 30% of the oversizing in the severe angulated neck like that, I use the forcing wire and push-up technique like like you present too, but I have endoleak type 1A in my case, and at that time I tried to collect with the endo anchor too, but it failed to fix it because of the too much oversize when we use this technique.
I'm not sure too much oversize maybe cause infolding,
Yep.
and maybe cause the leakage. I'm not sure because from my experience, 20% is enough, but don't use the stiff wire. You should change this technique.
Yep. Thank you.
Dr. Kobayashi, how much
Yeah.
oversize you do?
Yeah, I choose about 20% or more. Then in the case of the reverse tapering and below the linear artery, it's I use more oversizing because it's a reverse tapering site. Is I want to use this site to sealing.
So you oversize a bit more,
Yeah.
maybe 20% or more.
Yeah, or more.
Yeah, we also do the same thing. The question is, when we say 20%, 30% of what? Of the measurement. Now, who measure it? In the outer diameter. So I think the variables here is the measurement. So if we tend to be very generous on the measurement, then our 20% or 30% would up into even more, So that is one variable. So when we measure this, got to be very careful how to measure it, obtain that diameter. We like to oversize like Dr. Kobayashi do. We oversize about 30% for ankle neck. Maybe we were lucky. We haven't seen that problem with the endoleak and things. I believe that with endurance with that M-shaped design, it will prevent enfolding quite well. And if we do not too much oversize, now the question is, what is too much oversize? Yeah. I believe, now this is my personal belief, I think if we oversize less than 40%, now I'm a bit generous. If we oversize less than 40%, we're okay. Now, 40% of what again? The measurement that we obtain. I think that enfolding will happen if we oversize more than 40, over 50% that we see. 20-30%, very unlikely to have enfolding. And using with the push-up technique, it will give us extra fabric to approximate at the outer curve. Now, this is something I don't have this great experience like Dr. Kobayashi showed us, but I believe that until now, we may have to go back and talk in our team again. A bit oversized may be okay. What is a bit oversized? 20-30%. We also do that, but your experience have got to warn us that we have to go back and reevaluate our approach again.
I think another factor for cause of endoleak is the good conformation between the aortic wall and aortic stent graft.
I agree with Dr. Vila because conventionally we use the stiff wire, the twist or backup measure to make it try to straighten along with the sagittal plane. But if we use that is why we try to suggest that a bit oversized more than usually may make the graft apposition to the aortic wall quite well. But I wonder if we use the forcing wire with the push-up technique and make the stent graft go back to conform to the axis of the aortic neck. Maybe we may not necessarily to oversize up to 30%. And the case that I developed endoleak type 1A is maybe because of the angulation of the aortic neck, and it have a thick calcification of the aortic neck too. Thank you.
Thank you. It's 12 o'clock. I'd like to thank the panelists and our presenters for a wonderful discussion. Thank you very much. We'll be closing the session now.
Thank you very much. Thank you.